you're able to hit 2 patients per hour or at least close to it as a resident, the easier it's going to be as an attending. Like Dr. Sinnott likes to say, more patients, more learning. And the other thing to remember is we are a 4-year program, so that does give us a little bit more time to practice. In a lot of 3-year residencies, at the end of your 3rd year, you would be in attending a month afterwards. So try to kind of view your progress in that lens. Like if I went to a 3-year program, would I be ready by the start of my 4th year to do this kind of independently? So one thing that I recommend in order to help kind of improve your efficiency is timing yourself. So before you go see a patient, start a stopwatch, see how long it takes you to go through it, your H&P, and then come back and then see how long that took. Look at how long it takes to write a note. Look at how long that it takes you to put in orders and do all the other little things. And as you kind of collect this data over a period of a few shifts, you'll kind of see where you're spending actually most of your time. Another thing to think about is, maybe, I'm not saying don't socialize, but, if you're spending a lot of time, not being productive, that may be something that you can try to work on as well. Number 2, knowledge. Obviously, the more that you know, the less often you'll have to look things up, the less often you'll need testing, the less often you'll need consults, all things that will eventually slow you down. Obviously, there are going to be some consults that need to be done. You got a CAT scan, there's an API, you're going to call surgery, right? But, if let's say you don't know what an epiploic appendigitis is, and that's what you find on CAT scan, and because you're not sure, you contact surgery, right? When really it's NSAIDs and go home, right? So that's just one example of something where the more you know about a topic, the more time it'll save you as well. 3, I would say if you're able to rely on your history, physical, and your bedside sono in a lot of situations, you can cut down a lot of unnecessary testing, and that will also help you improve your efficiency as well. Being decisive. A lot of times, being indecisive will cause delays in care, right? Let's say you get a lab value back and you're not really sure what to do. So you go see another patient and then you just kind of waffle back and forth. I'm sure we've all been through this where we're just not quite sure what to do, but ultimately that will just lead to inefficiency as well. And let's say you do order a test. Make sure that when you do have anything ordered, you have a plan on how you're going to react for any sort of lab values that may be awry, or if you find or what you don't, or if you don't find what you're looking for either. How are you going to approach that? So make sure you have a clear plan for everything that you're doing and ordering. Number 5, batching. So when you get up, it is usually going to be more efficient to get up, see a number of patients, and then sit down, put in orders for all of them. Call all your consults, let the nurses know what you're doing all at once, as opposed to doing one at a time. Because 1, it's just extra walking for you, and that's going to eat up time. And 2, just because it'll help you kind of move the room a little bit faster, get workup started and things like that. 6, occasional shotgunning. Now, as an academic institution, we would prefer that you think very carefully about the orders that you put, and that is good practice. But once in a while, you'll see a chief complaint that you're going to need labs and things for, right? So, for instance, a patient with high-risk chest pain, multiple cardiac risk factors, multiple stents, they come in, they say their chief complaint is, feels like I'm having a heart attack again. There's really very little way around getting some sort of labs or an EKG at least, right? So you can just put those orders in ahead of time. Or let's say a patient was sent in because of abnormal labs, but they don't have a copy of their labs, right? So then obviously you're going to have to kind of repeat some of that stuff. So if you know that ahead of time, you can order it before you see the patient, and that'll help kind of improve your efficiency as well. Number 7, maximize your staff. So in other hospitals, you may have the opportunity to work with people called nursing assistants. And a lot of times these nursing assistants will do things for you, such as set up for your procedure, have all your size sterile gloves ready, repeat EKGs for you. They can irrigate lacerations for you before you go into suture them. They will have clerks that can do all your paging for you for consults, hospital lists, um, and then actually do pretty much all of the transfer paperwork for you as well, instead of having to do all of these things that you are used to doing yourself. Clerks can also call about labs that are taking too long, and some places you can actually have nurses put in orders when it's very busy, and you can just verbally tell them what meds you want to give, and then they can put those orders in for you, and then you just sign it later. So these are all things that can help you kind of move a little bit faster, that we may not actually think about too much because we're often have to do these ourselves. And then finally, when it comes to documentation, we do spend an inordinate amount of time doing this, especially with Old Quadramed where macro is a little harder to do. With Epic, dot phrases are your friend. Make sure, I recommend having a dot phrase for pretty much every type of chief complaint that you see. Macros for physical exams, but make sure you have enough uh, variety within them so that when things are different between each patient, you are able to, not just copy and paste and do the exact same physical exam for every patient. And in some places, if you work where they have dictation, like Dragon software, I actually really like that because you can do auto text as well. So it's a kind of essentially like a dot phrase that you speak, and then it'll kind of auto populate a full physical exam or whatever you need. These are all things that will help you move faster. And some places will give you a scribe, which I think there is definitely a learning curve in working with scribes, and there is a huge variability in how good they are. But scribes, I think, will probably improve your efficiency and documentation speed way more than any of these other things are. Okay. Now, the question is, how can you be an efficient community doc without disappointing D'Souza? I don't think it's really possible, to be honest, because there are a lot of things that you're going to have to do in the community that he may frown upon. And in terms of metrics and all this other stuff that you are kind of expected to do. But, it is what it is. So here are some examples of RVUs. So the first five are your E&M codes, right? From your level 1 to a level 5 chart. When you're over at UHB and you kind of see all of this stuff, when you get your feedback, this is kind of what's coming up. So with your E&M level 5, you can see kind of how many RVUs you're getting in 2019. And then the last one over there, the 99291, that's your critical care time. So now you have kind of an idea of, how many RVUs you can get for all of these different things that you're seeing here. So this is kind of less of a, not quite as important, but how do you increase your RVUs? One of the most important things in doing so is making sure that you document appropriately. A lot of times, if your H&P is lacking, little things here and there, or you don't document enough organ systems in your physical exam, then oftentimes you can lose from a 5 to a 4 or a 4 to a 3, and you can see that actually it results in a pretty big difference in terms of your RVUs if you just go down one code to another. Critical care billing. There's a lot of things that you can potentially bill for critical care that we don't. These apparently, as per CMS and Medicare acuity data, there's an 8.5% critical care time in terms of all the patient you see. That's average. So if you're going, obviously as a resident, it doesn't really count, but once you're an attending, you notice that you're barely doing 10% of your critical care times, and I would go over the rules in terms of what's critical care, and just get an idea of maybe I'm missing a bunch of critical care patients. Signing out. So apparently in a lot of places, when you sign out to if you sign a patient out to an incoming provider, then you kind of miss out on all the RVUs for that patient. So in places like that, the culture is generally not to sign anyone out, because essentially then you're just losing money in that situation. Obviously, there are times where you're going to have to, but then understanding that all the work that you did for that patient prior to signing out essentially will go to the next provider. Number 4, accurate diagnoses. This was a big problem with Quadramed, where, for instance, level 1 trauma comes in, they get a thoracotomy, chest tubes, all this stuff. And as a diagnosis, we would just put acute pain due to trauma. Obviously, acute pain due to trauma, getting admitted to a SICU doesn't quite make sense. So it's important that you put in all the diagnoses, right? Cardiac arrest, traumatic cardiac arrest, pericardial effusion, all this stuff that may have indicated why they had to go to the SICU or go straight to the OR. And procedures. So accurately documenting all your procedures, the site, complexity, the technique that you use is really important in order to bill appropriately. For instance, laceration length. If it's less than 2.5 centimeters or more than 7.5 centimeters, it's completely, and in between, it's completely different billing. If you do a simple versus a complex IND, also much higher RVUs. If you have to do, for instance, what makes a complex IND different from a simple is if you need multiple incisions, if you have to place a drain, packing, if you have to break up loculations, if you irrigate or probe, that all kind of points more towards a complex IND. And obviously the size of it will also kind of play a factor in that as well. Interpreting an EKG and, including specific phrasing like that you viewed and interpreted this independently without a cardiologist. And then kind of, rhythm, rate, all that stuff. If you put all of that, then that will actually count for RVUs as well. So obviously when it comes to procedures, the faster you're able to do them, right, the more efficient you can be. And, potentially the more RVUs you can attain as well. Obviously, you want to minimize taking too long on a procedure. So in terms of that, just as a kind of a side note, probably the fastest procedure you can do, I guess the most bang for your buck, is actually an IO, which I've seen actually some locums providers put in like unnecessary IOs, mainly because of that. I do not recommend that. Obviously, patient care comes first. One sec. So, but it is just something to kind of realize that in terms of each, procedure has a specific RVU associated with it. Okay. And generally, seeing another patient, right, will probably bring in more RVUs than doing a procedure. And that's why a lot of times you'll see in these places that instead of actually, doing the LP that, that a provider thought was indicated, sometimes a provider will actually just sign that out and then just go see, the ankle sprain instead. It does lead to some ethically questionable choices when you work in places like this that people like to do. But so just be aware of that. Obviously, do the right thing for your patient no matter what, regardless of what the billing issues are. And this is just a table with some common procedures that we do and how many RVUs you can kind of expect to get for all of them. I just want to highlight a few things. Like a shoulder reduction generates quite a few RVUs. The procedural sedation that you use in order to do a shoulder reduction is actually a separately billable thing. Some places will not allow you to do that yourself. They need a separate doctor to do it. So also just kind of be aware of that. And also as an aside, a ultrasound guided thoracentesis is about 3.2 RVUs, but if you place a chest tube, that's 4.5. So a lot of times a patient may just need a thoracentesis, but you'll also see kind of some RVU based places will place a chest tube just so that they can get more RVUs, even when it's not indicated. All right, so kind of final nuts and bolts of working as a locum tenens. You do have to pay your own taxes. They don't come out as, with every single paycheck like they do when you're a W-2 employee. So what you have to actually do is estimate how much income you're going to get over the course of the year. And then from that, figure out what is your total tax burden, and then divide that by 4. And you pay it in April, June, September, and January. And then in addition to that, you also remember, like, let's say if you live in New York, every quarter, you also have to pay your state taxes, your local taxes, and then there's a separate commuter tax that you also have to pay as well. Again, going back to insurance, since you don't get benefits in most cases, you're going to have to purchase your own health insurance, your own disability insurance, your own life insurance as well. So that's also something to keep in mind. And when you're insuring yourself for disability in life, you also have to keep in mind how much your salary is now, what you expect it to be in the future, and things like that. The big question a lot of people have is often because they read, should I do a sole proprietorship? Should I do an S corp? Should I, incorporate? Um, a lot of this decision is going to come down to your specific practice, how much money you're going to make as a locums, and if you bring in employee W-2 wages as well. If you also have a job where you're bringing in W-2 wages, because that will automatically be taxed, in most cases, it's probably the tax savings of doing an S corp probably don't make up for the cost it takes to set that up. Whereas a sole proprietorship is actually very easy to set up. It's free. So if you are doing full-time locums, it will probably make more sense to do an S corp or something like that. But obviously, speak to a tax lawyer or accountant for more specifics with your situation. And then lastly, there are a lot of retirement plans that a locums provider has access to, which are better in a lot of ways than what you can as an employee. So if you make enough, you can do a solo 401k. And with the 2020 limits, I think it's now 57 or 58,000 that you can put away every year in terms of tax-free, tax-deferred retirement income. Then if you have a high deductible health insurance, you can also set up a health savings account, which is essentially like, it's kind of like a retirement plan where you can invest in specific investment strategies, but it will grow kind of tax deferred until you need it for health related expenses when you get older. And then also there's the backdoor Roth IRA, which pretty much every doctor should be doing in order to get essentially when you retire, your Roth, withdrawals are not taxed. That is, and SEP IRA is also another thing similar to a solo 401k, but it's really only recommended if you don't make enough to contribute to a solo 401k. All right, so, I see a lot of questions. Okay, let's see. So liability, medical, legal coverage. So it's a good question. Most locums providers, in fact, I would say pretty much all of them will provide malpractice for you. One thing to check always is there a tail, so that if you leave a specific job or something like that, then you will still be covered for the time that you were working there. And then that's part of why the locums providers, the locums companies, the money that they get for the work you do is much higher than your hourly rate. So that's why there is some kind of wiggle room in terms of negotiating your hourly rate, is because they're actually getting way more money and they're using that to pay, their administrators, pay for your malpractice and all of that. Separate credit card used for medical expenses. Yeah. So if you have a separate card for, expenses and stuff, it does make your life a lot easier. And then also decreases the chance that you'll actually need an accountant to do all this stuff. And yes, I will. Yeah, you guys can get a copy of this. Where's the patient in all this? Good question, Beth. So obviously everything needs to be patient-centered. I was just trying with this lecture to give you guys a sense of what it is like providing care for patients as a locums doctor and what it means for you as a physician specifically. Any other questions?
Feel free to unmute yourselves and ask out loud.
Eden, it's Smriti here. I was wondering, how do you balance your locum shifts along with also your academic role at the hospital? Like, how do you manage that financially and also in terms of your your schedule?
So financially, I make a budget for the year, and like how many shifts I need to work in order to be able to pay all my bills at each kind of location that I work at. And then in terms of scheduling, what I usually do is uh, so my where I was doing locums, they would pay like a really high premium if you worked holidays. So I would preferentially work those holidays, with locums. So I'd block off, like for instance, July 4th weekend for them, and then I put like 24 hours off, and then I'll work a few shifts at downstate, like a day off, and then I'll do a few shifts at county, etc. This way, it's a little bit easier just to kind of have some continuity in where you're working on a day-to-day basis. Um, and then that way you end up getting maybe like close to like a week off every month, kind of as a block in terms of just kind of spreading things out all at once. And then in terms of academics, it's kind of, like for instance, the CCMF stuff, you just kind of find time to do all of that in between. Any other questions?